we'll share the slides actually, and we've got quite a bit of stuff for you today. So we're going to do obviously the latest quarter's update, but try and put it in context of that whole COVID impact and recovery. And the data is quite interesting this month actually. We've made some updates to the modelling tool, so maybe just go to the next slide, please, Ellie. We've made some updates to the modelling tool, and we'll cover that. As usual, it's the usual sort of housekeeping arrangements around. If you have any questions as we go, just put them in the chat. And I'm joined today, obviously, by Ellie, by Kirsten, by Mike, and by Aidan from the NHSBN team, so that they'll all be able to respond. And I think perhaps when we get to the end of each session, so for example, when we finish talking about beds and adult services, I might pause then, and if anyone has any questions, there'll be a chance to come in. And then we'll do community-based services. We'll look at IAP briefly, and Ellie and Aidan will give us an update on the latest modelling tool and the changes in the functionality there. And that should hopefully get us to that targeted session on eating disorders, which we've put in about 30 minutes for. And what we're bringing there really is the UK data and the Southeast story within it. And obviously it's the first time we've had a discussion about this, so there is a little bit of scene setting. Okay, so hopefully that's all fine. And if we move on, Ellie, first of all, just hats off to everyone. Thank you so much for your data submissions. And I think once we got going, it seems a long time ago now, doesn't it? But in the middle of last year, it's really been flying, and every single provider has given their data on a consensual basis every month, really. And I think that's given such a richness of data. And obviously all of this stuff is in the modelling tool. So we've got this great asset base in terms of the empirical evidence we can look back on. And obviously we can roll it forward in terms of those future scenario modelling tools. But hopefully, this can act as a supplement to the work of the regional team anyway, and we do think actually the Southeast has got some really good data enabled at sort of region and system level as well. It's some of the best that we've seen. So let's just go into that national context quickly. This comes from our main 2021 benchmarking findings this year. So it's just a reflection on the current shape. It's a position at the end of March really in terms of the position for England. So there were just under 18,500 beds reported. These are just NHS provided beds, and there'd been a slight reduction actually compared to where we were the previous year. And obviously that reduction could have played out over many specialties really. We had just over 700,000 people being supported on CMHTK. So that's all types of CMHTs, from EIP through to old age services. And IAP caseloads had reduced actually during the pandemic. I think that was one of our observations, that IAP recovery process, would kick in during 21, 22. But unfortunately, there was such an impact to referrals and the ability to see people at the start of the pandemic that's reflected in some of the IAP volumes. But overall, obviously, on the right-hand side there, the beds account for only about 1% of capacity. About 6% of mental health service users might be admitted to a bed over the course of the year. About 41% would be on a CMHT caseload. About 58% would be being supported by IAP services. So it's a very clear hierarchy of how people would access their care. I just want to share with you, this isn't a story about the Southeast now, but it's really important to sort of present it to everyone today, which is about the inequalities position. And this came from our main project this year. So it's the national headlines for the NHS about the disadvantage and inequality that minority community, that BAME patients experience in the mental health system. So the way the chart works is that the left-hand side is the background population of England and Wales, and basically 84% of people identify as being white or white British, 4% in purple, black or black British, 8% Asian or Asian British, 3% people who identify as mixed race, and I think it's 1% people of other ethnicities. The second column along shows what national CMHT caseloads look like. So there, it's broadly aligned actually with the core ethnicity for the country. So again, reasonably encouraging there, although there are fewer Asian British people on caseloads. And the 5% other ethnicities may well be a slight coding issue. However, when we go to inpatient admissions, the third column, what we see is we see the start of the story around inequality, with BAME patients more likely to be admitted to mental health services. And it's particularly clear from that data that it's Black British people who are most exposed, actually, and they're twice as likely to be admitted to a mental health bed as the rest of the population. Then the final bar explores the story of detentions. This is how many people are detained under the Mental Health Act by the different broad ethnicity categories. And unfortunately, that's where we see really the strongest skew. So what we're seeing is that BAME patients are twice as likely as a group to be detained under the Mental Health Act as white British people. And unfortunately, it's Black British people who are bearing the brunt of that, and they're 3.5 times more likely to be detained under the Mental Health Act than the general population. The story plays out even worse, actually, when we look at the different kind of beds, like this on the next chart. So we're just exploring the different specialties now. So, for example, adult acute services, you can see there is a skew, and again, it's a story of the overrepresentation of Black British people in terms of admissions. But where we see the strongest skew really is as the degree of acuity and restriction peaks. So in PQ, in low secure, in medium secure, maybe in long-term rehab as well, we've got this astonishing overrepresentation of BAME groups. So Black British people are 5.5 times overrepresented in medium secure services. So we've not done a specific Southeast drill down on this, but it might be something to consider for next time we meet, in terms of setting a regional platform that we can use to monitor against in future. If we quickly go to the CMHT stuff on the next page, and again, this is NHS wide. There isn't anything which we could really define as an acute CMHT, but there are proxies for that. So, for example, EIP services, maybe assertive outreach, forensic and rehab again. And again, you'll see the same story playing out there. But then there are some areas where we've perhaps got underrepresentation of BAME groups as well within services. So I think it's a useful baseline position to be aware of, and it would be great to get your comments in the discussion at the end about what you might want to do with this going forward, perhaps. Okay, so I hope that was useful context from this year's national data. We're now going to look at the regional story. So we'll start with inpatient care, and we'll kick off with a map. So a map is better than what 10 charts and 10,000 words, but hopefully gives some illustration here, so that we all know that the region has a low bed base, and that's played out in so many conversations recently. So the national UK mean average is 21 acute beds per 100,000 population in the working age adult groups. South East position is unchanged really at 14, and you can see that the region is pretty light coloured there across the board. So I think it might be Sussex who come closest to the average, but everyone is below average. And we'll look at that in a little bit more detail in a second. Obviously, the Isle of Wight position is skewed by economies of scale. So we find most beds in the north and most beds in London. So let's look at the South East COVID story now. So the first blue bar is where we started out in the year pre-COVID, so 1920. The red bar is the story of the COVID year, so what happened in 2020. And then the green is really, as Katrina said at the start, it's that longitudinal story on a month-by-month basis from April through to October. I think the South East is probably the lowest change region of any. There's been a real stability about the response, you know, maybe a slight decommissioning of some capacity at some points and then bringing it back on stream. But the good news is that we are at the end of this process. Well, we know we're not at the end, of course, but 19 months on, we've got the same capacity as where we started from. So that stability of provision has been evident really throughout the story, I think, even though nationally some of the bed capacity did drop in the early months. So let's have a look at the position by provider now. So remember, this is the total UK lineup of services on the next chart, Ellie. Okay, so the top one, remember the code for this is that's pre-pandemic. So it's 1920. So we're ending this in March 2020. So the length of stay then was 35 days overall. You can see that we had this really quite wide range between providers, from Oxford Health on the left, being very much in the top decile through to Solent being Solent and Kent being very much at the other end of the scale. So a lot of variation between providers. What we see in the national data at the moment is that the average length of stay it's not moved too much. It's gone up marginally to 36 days. This is for acute admissions. But it's interesting that the distribution amongst the Southeast providers has changed quite a lot actually over the course of COVID. So Oxford Health have really encouragingly moved towards the centre of the range. So they've managed to reduce length of stay quite a bit. Surrey and Berkshire have moved out a touch, and now Surrey have got the highest length of stay in the region, followed by Berkshire, Isle of Wight. So those trusts are above average, and Oxford Health on the average. And then we've got Southern, Sussex, Kent, and really fascinating, Solent are now reporting the lowest length of stay in the NHS. That Solent model remains fascinating and one of ongoing interest really about the balance between the inpatient capacity, how patients experience it, that sort of approach to risk, and how people are supporting the community. So that's the story of the region's position in the national range. And this is what's happened to average length of stay for the region's providers over that 19-month period. So remember the pre-COVID year, we're just showing there in blue 33.6. We did lose average length of stay, some length, if that makes any sense whatsoever, during the COVID year, particularly at the start of the pandemic when people were discharged at scale in April. But what we see now is what we might describe as a build-up of pressure. It's not the highest length of stay we've seen in the region, which was actually in May of this year, where it was nearly 41 days, but we can see some of that build-up actually through the autumn. So the most recent data for September and October suggests about 38 days. This would start to position the region towards the top end of the national range now, towards the upper quartile. So the region at the moment is positioned between the mean and the upper quartile, but it's moving in the direction of the upper quartile. So I think that would suggest that there's pressure within the system, especially when you think that Solent have got the lowest length of stay in the country. Okay, so that's the length of stay position. This is that story of granularity within the length of stay position. So we know that some patients would have really short admissions, and obviously that there are more of those patients within Solent. And that's shown on the far left there, where 14% of admissions are patients who stay 3 days or less, but they only consume 1% of total bed stock. But then on the right-hand side of this chart, we see that patients who stay a long time. So it's that term that people use in terms of stranded patients, so long-stay acute patients. So patients who stay for 90 days or longer, they account for 7% of admissions, but they consume 39% of all bed days. So optimizing that cohort becomes so important for the story. And we know that the CEO group in the Southwest are looking at that through their local complex patients work. The next chart is bed occupancy. So again, this is the region's story. This is interesting actually. So the region started out at 94% pre-COVID. In the COVID year, obviously, because we had low occupancy in April, May and June, it dipped to 87%. You can see that on the monthly positions. But we seem to have this position which is stabilized now, around in the high 80s, 88, 89, maybe some months 90. So it's really encouraging to us, actually, that the overall occupancy has fallen by about 5% for the region. So it's obviously intriguing to see what the use of out-of-area placements has been in association with that. And obviously we're talking about a broad regional average, and some providers will have a lot more local pressure than this, but there has been quite a gradual stepping down actually across England, where average length of stay, we are seeing pressure, but bed occupancy has come down generally across England from those sky-high days that we all remember when it was 95 or 96%. We're not quite at those sort of RC Psych recommended levels of about 85%, but there is a suggestion that things are slightly easier than they used to be. Okay, one of the other big factors that changed from the COVID was use of the Mental Health Act, so we'll look at that now. And so this is detention. So the top is pre-COVID, and the national average pre-COVID was 44% of acute patients were detained at the point of admission. And the South East was very close to that, 45%, but there was a striking range. So Oxford Health, remember, they had the highest length of stay pre-COVID, also had the highest use of the Mental Health Act. And that's you can see those things being really intertwined when things are super tight. But then Isle of Wight had the lowest use of the Mental Health Act. Nationally, the use of detentions has increased, so it's now 48% in October compared to 44% pre-pandemic. So it's eased a little, but use of the Mental Health Act is 10% higher in acute beds. But the region actually has really increased. So there's something going on behind this story. So the region has gone from 45% to 55% over the course of the pandemic. So this may speak to us about patient experience, that patients are being brought in on an involuntary basis. Do you want to just jump back quickly, Ellie, sorry, to this one about the trust position within it? So encouraging that Oxford Health have moved slightly to the right, but really fascinating actually that it's Solent with that short stay who are using the Act, but they're using it in a really flexible manner. So patients are not necessarily staying for 28 days when they're detained. So again, there's some real interesting practice taking place across the system here. And again, Surrey are low and Isle of Wight are still low within the system at the moment. Okay, and then Ellie, sorry, I delayed you on this one, but the next chart is that sort of story of the increase of the use of the Mental Health Act across the South East. So you can see where we started from. I think it's probably fair to say we jumped really quickly to that higher plane of about 20% higher use of the Act within the region. So that's where we are now, and it'll be interesting to see how that one plays out, because obviously it has an implication for length of stay, and it certainly has an implication for patient experience. So we look at the patient, we look at the community. Sorry, Katrina, I'm happy to stop there if anyone has any questions before we go into the community side. I'm not sure whether anyone wants to raise a hand there, or should we just crack on? I'll take no hands as permission to crack on if everyone's okay with that. Fantastic. Okay, time's up on that one. So let's look at the community data then. So what we have here is the overall contact rate. So remember, the top chart here is the pre-COVID data. So the region was about 12% below the national average there, at about 26,000 contacts per 100,000 population. What we see nationally now, though, is that the national contact rate has fallen since COVID. So fewer people get interventions now than they did pre-COVID. So is this about the difficulty of providing care? In the South East, we're actually looking at 15% fewer contacts being delivered by CMHTs than we were pre-COVID. Nationally, the contact rate has fallen by 8%. So again, the region has started to move away from that national story, and this is a very different story than the one we discussed at last seminar, actually, where the region was pretty locked into that national position, and then 2 seminars ago, the region was doing better than the national position. So is there something that's got more difficult about providing care now? If you just go to the next slide, Ellie, we've now got the delivery of those contacts. So this is for the full year 2021, and we are mapping the South East position against the rest of the UK. So it's pretty close actually, but if you start with the UK one, there was a really clear 60-40 split last year in terms of 60% was virtual care and 40% was face-to-face, and most of that 60% virtual care was actually delivered via the phone, which you'll see there in that bottom chart in terms of the 54%, and then the residual 6% was the digital care. This is adult CMHTs we're talking about now. The South East was not too far away from that, but actually the South East delivered fewer face-to-face contacts. Just 36% of all contacts were face-to-face in the COVID year. 8% were digital and 56% were via the phone. So I think there is a big discussion point for everyone here about what the aspiration is for the future and how we return safely and appropriately to face-to-face care. Of course, it's not going to be like we were pre-COVID, but at the moment, the region is a little bit of an outlier in terms of relying on virtual care. Okay, so the next one, Ellie, I think is the digital care. So the 2 best performing regions in the country at the moment on digital are the South East and London. And the top chart there is the national average story, I think, of where we got to with use of digital. So it never got that high in terms of adult CMHTs. The region has always did better than national average. And in October, it was still at 9% of all activity was being delivered through digital platforms. And best in the country was Oxford Health, followed by Berkshire, followed by Sussex. So 3 of the top 4 places nationally were occupied by South East Trusts there. And we just had Isle of Wight actually that was reporting really low volumes. So the embracing innovation is something that's happened really strongly. Quick look at IAPT, Ellie. So the big story about IAPT is that contacts and referral rates are down. There is a recovery taking place now. And then, so we've just got the absolute volumes there, the latest data for October. They're not benchmarked, those per 100,000, but the South East does have some big providers, obviously. Oxford come through prominently there, Sussex, Southern, Berkshire too. When we show non-face-to-face care, this has been a game changer. Even now, 19 months in, we're seeing nearly all care in IAP being delivered non-face-to-face. So only 6% of contacts nationally are delivered face-to-face in IAP, so it's pretty much a virtual service. In the South East, it's only 4% of contacts are being delivered digitally. And the only provider of note, really, that has a face-to-face offer at the moment seems to be Southern, where I think we're talking about 10% of contacts, but pretty much everyone else has a completely virtual model. And Ellie, let's look at the digital next, I think it is, yes. So again, the region has done fantastically on digital. So the latest data, England average, 26% of IAP care was digital in October. The South East was 36%. So Southern and Solent were the two best providers in the region. So if you look at Southern's Southern there, about 46, 47%, and on top of that, 10% face-to-face care. Southern are the first trust nationally to flip away from reliance on the telephone. So less than 50% of care for IAP now in Southern is delivered via the phone, but other providers are still more expert on that one. Let's look at the final one, Ellie, which is the story of digital. And that's how digital took off in IAP, really, over the course of the pandemic. So it seems to have settled, I think would be our position. So for pretty much all of 21-22, we're operating around about a third of all care being delivered digitally. But face-to-face has not come back, and the phone is still the dominant medium across the country. So let's look at CYP now. So we've got the one big blockbuster chart on this one for the NHS. So this is the blue area shows the increase year on year in referrals to CYP. Remember, CYP referrals doubled in the last 8 years. So it is the fastest growing specialty in healthcare. The penultimate blue bar is 1920, and then the final blue bar is the COVID year, 2021. And so we did see a dip in national referrals, which were 12% lower in the COVID year than they were pre-COVID. And the reason is, you'll see from the monthly red bars there, that in the early months of the pandemic, because schools were closed and you couldn't get to see a GP, CAMS referrals really just did fall through the floor. So we had a 53% reduction in April. But then the rebound has been fastest in CYP of any specialty, actually. And you see that for several months there, we've been running super hot, really, across England in terms of overall referral rates. So we've got at least 7 months there where referral rates have exceeded any known historic rate in CAMS. So the South East largely mirrors the national story in terms of the overall range, and actually the South East has got some of the highest demand in England. So let's just look at that next, Ellie. So we've got the national map here, and this is caseloads actually, and you can see there are some hotspots there within the South East. So Surrey, Thames Valley coming through particularly dark. A lot of variation is the other big message around CYP provision. So let's go to the next one, Ellie, in terms of caseloads by provider. So overall, the national average, this is at the end of October, is 2,094. So 2% of all kids were on CAMS caseloads at the end of October. The South East, though, had nearly 3% of all kids, so 2,760 were on CAMS caseloads at the end of October. So it's 32%, so a third higher than the UK average. And you can see the distribution there. We haven't got data from every provider, but Berkshire was second highest in the UK. Solent were fourth highest. The two, so Hampshire and Sussex there from Sussex Partnership were pretty much in the top quartile as well. Surrey average, Isle of Wight just below average. We just had a slight issue with Oxford, who seems to have flipped away from super high. So maybe that's about a discharge programme. I'm not sure, but the Oxford data has gone slightly unusual. However, Let's look at contacts on the next one. This is fascinating, actually, is that what we see is that Oxford have moved to the left now, as have Surrey. So what this data is telling us is that Oxford have got low caseloads, but super high intensity for the kids that are being supported by the CYP teams within Oxford. So overall, the region's contact rate is very close to the national average. It's just that the region's got high referrals and is carrying high caseloads, but the overall number of contacts, number of interventions is round about the national average. And that might actually speak to problems with capacity, actually, in terms of responding to the high caseloads and responding to high referral rates. So again, this is like the adult chart. It's got one additional gradation within it in terms of segmentation of the data. But the bottom chart there, in last year, in that first year of COVID, only 28% of all CYP care nationally was delivered face-to-face. So most of it was virtual. So 72% was virtual. And you can see how that segments. Digital was a big chunk, 19% nationally. Telephone, 45%. And then we have this non-specified additional virtual mediums. Look at the southeast. So not a lot of face-to-face care took place last year, just 13%. So we're looking at something like 1 in 8 contacts was face-to-face last year. 29% was digital, so a great embracing of digital across the region. 37% was phone and 21% non-specified virtual. So I think we can look at the digital in a bit more detail on the next one. So the region, again, is with London is the best performing region for digital in CYP, and it's really kept up a very steady digital presence within CAMS. And we've got Sussex, both the Sussex and Hampshire provision, also Oxford Health, who were leading the way there, and Berkshire also very close to that top quartile rate. Okay, I hope that was useful. Before we go to the new toolkit, which Ellie's going to talk to us about, we've got a chance for a discussion now if anyone wants a question about any of that baseline data. I think we're approximately on time. We have time for questions if anyone would like to raise any points.
Yeah, any questions, reflections? Hi, Adam.
Hi, Steve. I've put it in the chat. It was just a question I was thinking when you were talking about some of the benchmarking data, because I know that some of the Hampshire Isle of Wight geography has their IAP delivered by Dorset, and I'm just thinking how we would pick that up, because obviously that might have an impact on some of the data we get, because it won't come under the other trusts in the southeast.
Yeah, we need to look at that, Adam. We just need to check whether that's there. It's a really good point. Ellie, can you come in? Do you know the answer on that one? And it's fine not to know the answer.
No, that's fine. So the IAP data we get comes directly from the trust. So it depends whether Dorset in their monthly returns are including sort of all aspects. So we'd probably need to get some clarification from them on that. But it's all submitted. The data that Steve was discussing, this has come up a couple of times in the chat as well. The data that we've talked about so far is primarily submitted by NHS providers. So what we've done within the modelling tool, this is a big spoiler because it's coming up in just a second, but we've included a link to the NHS digital site that does include, especially for Kent and Medway, it does include those non-NHS providers as well.
Because I was thinking as well, I think probably Deborah's mentioned it in the chat, where there's, this is just one example where providers might work across the different regions, and whether we capture that. Because I think it might make a bit of a difference.
Thanks, Adam. Yeah, we have made a request to NELT actually for their data to be segmented, and hopefully when we get to the next iteration of the modelling tool, we should have that there. But just bear with us. You're right. We need to. It's not just to provide a story. This is it. It's about the areas that are being served. Yeah. Okay. So Deb, sorry, I just picked up your question there. And I'm just looking at Emily's question there about the utilisation of Tier 4. I think it's really difficult, Emily, to talk confidently about relationships between community and Tier 4. The one thing I hope this is of interest to people is that we're doing some work in another region, with the Northwest region, actually, where we've managed to network the national services from Sweden and some of the state-based services from Australia into the mix around CYP Tier 4. And these are really interesting, of course, because the average length of stay in CAMS is about 71 days at the moment across the NHS, just for general behavioural admissions. But in Sweden, it's 8 days, and in Australia, it's 9 days. And there's just a completely different model of care which plays out. And in Sweden, for example, a parent is always admitted with a child, and it's very much that acknowledgement that, you know, a child crisis is the family crisis, and it's a core family therapeutic approach to trying to resolve that admission with a massive community service sat behind it. So I think we'll be really interesting, maybe in a future session, maybe coming back and sharing some of that learning, if that would be of use to people. It's so radical in many ways compared to what we've been used to in the NHS. So Sweden have got fewer beds per capita than England, but they're admitting about 7% more kids than we are because they've got this super short stay model. Anything else, Katrina, or should I hand over to Ellie to talk about the modelling tool?
No, that's great.
Sorry, there was just one other point from Gavin. I'm assuming this is for CYP mental health, to understand what came first for Oxford, higher contacts or lower caseload. Just a query.
Yeah, I'd be really interested to hear from the trusts themselves there, Gavin. I'm not sure of the answer. I mean, I was surprised that Oxford's caseload have shifted to the right, because they were always one of the trusts who were really always been present for many years, actually, on the left-hand side of the chart with carrying high caseloads. So Oxford CCG, for example, have low investment in mental health. I think they're second lowest in the country or something like that. But it's very much skewed towards CYP, where the CYP investment is decent, but the adult investment is quite low. So I was quite surprised to see the trust move to the right. But the reassuring bit is that the interventions are still being delivered at scale in Oxford. I'm not sure whether we have anyone from the trust on the call today or anyone from the CCG who might know a bit more. Okay. If that's okay, then I mean we can pause regularly. Actually, I think that there were some really helpful points made there. But Ellie, do you want to now pick up with the illustration of the modelling tool and what's changed?
Sorry, Steve, I was just going to come in and really briefly, before we move on, no, it's fine, and just mention that I think a number of you will be aware that there's been some very clear lines from the national team around IAPT and informed choice for step 3 of digital or face-to-face intervention. And the lines for telephone are that there is no evidence base for step 3 telephone interventions, and it's only by exception if somebody isn't able to use a video online treatment. So just to kind of reiterate that, really, and obviously we're a long way from that at the moment.
Thanks for that, Katrina. It's really, really important point, because the data on IAPT seems to have settled, and we haven't seen much change, whereas the CYP and the adult data both have a sort of recognisable peak and then slight decline actually on digital, but the IAPT data is very steady, and there hasn't been any return to face-to-face care, which is why I think that experience of Southern in at least delivering 10% of interventions is really interesting.
Yeah, thanks, Steve.
Okay, Ellie, do you want to move on with the modelling?
Yeah, no problem. So I think before we move on to the eating disorders section of the presentation, we just wanted to flag, particularly following your feedback from the last session, some updates that we've made to the modelling tool. So I'm not going to do a full demo. I'm aware that some of you are quite familiar with the tool by now, but just to flag some things that you might or might not know, which will be included within the next iteration of the modelling tool. So in terms of the basics, the new tool will span April 2020 through to September 2021. So it's an additional 3 months to what we saw last time. I've just got a screenshot here of the home menu. So a couple of new bits on here. So we have following the feedback that we've just had through as well, so it's quite timely. We've actually added a link to the NHS digital IAPT tool in there, so we're aware of the limitations of the data that we've got. Obviously, it's useful to have it, but we're aware that because it doesn't cover those non-NHS providers, for some areas in particular, it's not representing the full picture. So what we've done is we've just added a link to that external tool within the toolkit as a recognition of that, really. In addition to that, we've also got the new out of area placement section. So alongside adult mental health data, CAMS data, IAPT data and learning disabilities data, we've now got this new section that's available via the homepage. And just to reiterate, other than the two new buttons that we've got, the remainder of the data comes to us direct from trusts as part of the Mental Health and Learning Disabilities COVID monthly tracker. And within the tool, we have the UK-wide data, and then we drill down as well to the southeast. So these are, again, a couple of just screenshots for those of you who may be less familiar. So you can see at the top what we've done is, alongside the existing sections, we've now got a new section for out-of-area placements. So when you click on that, this then takes you through to a sort of an overall menu where you can select metrics at either UK or regional level. And when you click on that drop down, you'll get a number of metrics for out of area placement data. So this is with data source from NHS Digital. Currently it only goes up to August, so whereby the remaining sections of the tool run all the way up to September. We're just a month behind for the OAP data, just due to when it becomes available. But it does take you all the way through to then. And then where applicable in the denominator section, you can benchmark your data. So particularly in the previous sections, so the adult and the CAMS, what you can do is you can view the data at sort of a raw data level, so just without that benchmark applied, and then you can add those denominators on, so per 100,000 population or as a percentage of total contacts, whatever's most applicable to those metrics. So in addition to the new out of area placement section, I also just wanted to flag that the analytics sections have all been extended. So where previously these ran until the end of December, we're now 3 months further on, and they take us all the way up to the end of March 2022. So you can see in that expected admissions column, so this is an inpatient trajectory, that data's been collected what we would expect based on your annual 2019-20 pre-COVID return. And what we've tried to do is ascertain where that sits in accordance to what you've submitted to us each and every month. So you can view that at an all southeast level to see where you are regionally, and you can also view it looking just at your trust, depending on what you're utilising the data for. We've also tried to make it as interactive as possible. So you can see in red I've highlighted there the additional options. So you can change whereabouts you would expect to be, you can change the time scale, and there are a few different recovery assumption options in that first drop down as well. So I appreciate that was a whistle stop tour, and I'm sure at some point we'll be doing another more thorough demonstration of the tool, but we did just want to highlight today some of those options that are available within the tool, and also the new elements that we haven't spoken about before as well. So I'm going to hand back over to Steve now, who's going to take you through the next session, which is around eating disorder services.
Thanks for that, Ellie. Really nicely described, and hopefully that the tool is really visual, and that incorporation of the OAPS data and also the link to the National IAP tool, I think are two really helpful additions. Does anyone have any questions about the tool before we move on to the eating disorder section? We've got a question in the chat from Callie, Ellie, about how the tool can be accessed.
I was just going to respond to that one. So I'll make sure that we send a copy around the latest version with the kind of the notes from this meeting, but it has also been uploaded to the NHS Futures site. So for those of you who have access to the mental health comms, long comms, which comes out every 2 weeks, you should also have a link to the Futures site. If you don't have access to that, please let me know, because we'll obviously need to make sure that everyone can access the tool.
Thank you, Michelle. If everyone's okay, then should we move on to the eating disorder section? I mean, it's the first time we've had a conversation about this, and what we've done is we brought the NHSBN's national data. We've highlighted Southeast providers, but we've shown them quite generically. I hope that's okay with everyone, so we can have a regional conversation, but it's not about any specific provider. And that's really because this was not in the sort of original consent protocol that we agreed with the trust, but it certainly doesn't prevent it becoming part of that in future. And it would, I think it'd just be good to get everyone's reaction actually in terms of your own local experience and what the data might be saying to us. So Ellie, if we move on really, so we're talking about both adult and CYP eating disorder services, and as usual we'll look at inpatient care and we'll also look at community-based provision. So this is just looking at NHS provided beds, because the independent sector are big players in the eating disorder market. About half of all the beds that are provided to the NHS are delivered by the independent sector, and actually the Priory Group are the single largest provider of eating disorder services to the NHS. But when we look at the lineup of inpatient capacity, it's a really small specialty actually. So there are 450 beds, but only about half of them are NHS beds, which is what we've shown here. So about 1% of capacity, compared to 36% for acute beds, 5% for PQ, etc. So we have more eating disorder beds, NHS eating disorder beds, perinatal, but there's not a lot in it in terms of having intrinsically low levels of provision. And this sort of gives us a bit of a clue actually about what the story is with eating disorders as a specialty. And I'll wait to come to this in a second actually, right? So we've highlighted one NHS provider there within the region. So as I said, about 450 beds available within England at the moment for adult eating disorders. About half of those are delivered by the NHS, and actually the largest NHS provider is placed within the region. I'm sure we all know. I'm sure we all know where that is. But so we do have a centre of excellence within the region. I think is one of the observations to make here. But you can see that most units are averaging around about 12, 13 beds. There are some small units as well. So it is quite similar to the perinatal capacity, which is out there as well. So if we move on, bed occupancy has been increasing in recent years, but it's still one of the lower occupied specialties, which always fascinates us. So nationally, in the COVID year, bed occupancy was 69%, and that fell actually from the pre-COVID year when it was 76%. So it is on the low side. Obviously, we can draw comparisons with elsewhere. So adult acute was about 88% last year, and PQ about 85%. So it's low compared to other adult specialties. So there must be something about this. We know there's demand out there because people do overflow into general adult facilities, into general medical beds and gastro beds, for example, because of lack of availability of specialist mental health provision. So Ellie, if we just move on to the length of stay, nationally, last year it was 91 days, the year before it was 95 days. So we're talking about relatively long stay admissions. Just to put that in context, obviously, an adult acute admission might average between 32 and 35 days. A PQ admission might be about 45 days. So we're talking double that length for an eating disorder admission. So we know that within that admission, there will be there will be feeding taking place. There will be some form of therapeutic input as well. But that package is a long stay package. So there's something within that perhaps about the eligibility criteria and the BMI on which that admission takes place. And we know that how that takes place in England is slightly different from how it takes place elsewhere. Although again, credit to the NHS in England, not every country outside of the UK actually recognises eating disorders as a psychiatric specialty. So we are one of few countries where it is a recognised psychiatric specialty. But you can see that the variation at length of stay there, which can run up to about 5 months, but then some of the shorter stay facilities are circa 50 days. Okay, and within the region, we're around about that national average. This is an issue for us actually, and it'd be interesting to get people's observations on this when we have the discussion. But we think there's actually quite a low skill mix within inpatient eating disorder facilities, and this is something we see in CYP as well, really, really strangely. But what happens when we explore the MDT within inpatient facilities? Well, registered nurses are 33% of the team. The largest share of staffing, though, are unregistered nursing staff, so support workers, who are 42%. of capacity, and then it's the admin team at 5%. But no providers were reporting any paid peer support workers. We didn't have any evidence of social workers within the units. It was pleasing to see OTs at 4%, so 1 in 25 staff members would be an OT. But the clinical psychology input was really quite low as well, at 3%, given that this is the core intervention. Consultant psychiatrists were 2%, so circa 1 consultant psychiatrist per unit. And then the training grades were really quite thin on the ground as well. So the question I always pose to people when we talk about this is, would you design it this way? Or is this a sort of an artifact almost about available funding, about nice, safe staffing ratios as well in terms of nurse staffing? Because we have a very low therapeutic core here. And it's actually lower than we would see on an acute ward, which, given the complexity of the cohort, is surprising to us. So a bit of challenge there in our observations, but it's what the data is saying to us. And if we move on, Ellie, to the next slide, we'll look at community services now. And again, there's a bit of challenge from us on this one as well. So referrals per 100,000 population. So in absolute terms last year, this is not a benchmark chart, but across the UK, there were 22,000 referrals made into UK eating disorder services. So that's UK-wide. And we would expect the NHS in England to be accounting for about 85% of that. And in the South East, there were just over 4,000 referrals, so 18% of the total. And we had 5 providers give us that data. So the mean average per 100,000 adult population is 74 referrals per 100,000 adults. The South East did have high referral rates at 103, so 39% above that national average story. So, and pretty much all providers were above the average. So I think what we can take from that is we had high recognition of the need to make referrals and a recognition of demand within systems, which was above average. But we've got concerns about capacity actually within eating disorder services. So let's quickly move on, Ellie. So the next one is the referral acceptance rate. So nationally it was 77%. The South East was just above average, but you can see how that was achieved because we've got one provider that reported they accepted all referrals, and then the other 4 providers were below the average. So that often a lower than average acceptance rate might tell us something about issues about mobilising capacity and about choices being made about the patients that were accepted. And if we move on, Ellie, the next one is waiting time. So the average waiting time last year was about 8 weeks for an eating disorder referral. So it's split about 4.8 in terms of referral to initial assessment, and then about 3.6 weeks beyond that to be seen, to be added onto caseload by teams. So it's perhaps slightly longer than we might hope for, so 2 months, given that often people are in some distress and there might be comorbid physical symptoms as well, very evident by this point as well. And if we move on, Ellie, to the caseload. So this is a discussion point. It's not just for the South East, it's for everyone really. But nationally, this is UK-wide, there were 11,312 patients on eating disorder caseloads across the whole of the UK, and 1,900 of those people within the South East. So about 17% of the total there. So the South East had slightly higher levels of representation. We think the big issue, though, is that there's a huge treatment gap here between where the NHS is as a whole in terms of the number of people being supported on caseload and then background population morbidity. So, for example, BEAT estimate that there are 1.25 million people in the UK with a diagnosable eating disorder. And if you compare that with the 11,300 who are on caseloads, it's about a 1% representation of people who may have a diagnosable eating disorder and those who are actually currently being supported by services. So the region is slightly better than the national average here, but there's something about, is this the psychiatric specialty with the largest treatment gap? It's a sort of an open-ended question, this one, but we think the evidence suggests quite clearly it is. If you remember where we started out in terms of CYP with the different national strategies, where the aspiration was to move from 1 in 4 kids who needed care to 1 in 3 kids accessing care who needed care. And it's a good news story that real progress has been delivered on CYP. we're talking about potentially here 1 in 100 people who have a case for care actually being in receipt of that care at the moment. So it's quite sobering actually, and it's a slightly more optimistic story on CYP when we get to that in a second. But because the treatment rate is about 2 or 3 times higher in CYP for child eating disorders than it is for adults. But the biggest gap that we see, the biggest treatment gap we see is for adults with an eating disorder. So just moving on, Ellie. The contacts delivered nationally, just over 250,000 contacts were delivered across the UK. South East was about 14%, so that compares with, I think it was it 17 or 19% caseload. So it's a slightly less intensive intervention in the South East, but the region's very much within those interquartile ranges, but the region's holding slightly higher caseloads than we would expect to see compared to the national average. Okay. And in terms of the digital contacts, again, the region keeps up its great track record in terms of digital care here. So it was the best performing region, and last year about 47% of all contacts were delivered via digital applications or video. So great performance by the region's providers really in keeping services available during the pandemic. And of course, a lot of the anecdotes were about an increased presentation of eating disorders during the pandemic. So the workforce, this is now the community team. We've got to remember that the national benchmark for all CMHTs is about 102 staff per 100,000 population. And the eating disorder team within that 102 staff is 2 of those staff. So it gives you a feel there that about 1 in 50th of the national capacity that we have in terms of the workforce are eating disorder specialists. So it's a very low bit of the overall CMHT capacity. But again, good news in the South East, it was higher than that, it was 3 staff. So again, there seems to be some local prioritisation of eating disorder responses, but it's against the story of a very low level of provision across the UK. Because I think it's fair to say that, and I'm not critiquing anyone here, but the strategy for UK eating disorder services it doesn't feel like it's a concrete thing at the moment with money, with absolutely tangible targets. We know that it's work in progress and it falls within the overall aspirations of the long-term plan, but there is a bit of a gap at the moment. If we move on then to the community skill mix, I think what's particularly pleasing, remember we're just talking about 2 staff out of 102 on average here, but this is where we see an incredible richness of the MDT. So there are excellent teams out here. It's just that they're small teams. So we're not, the unregistered nursing staff is very small at 8%. We've got a really good mix here. So the clinical psychology core is very evident. They're the 2nd largest group after registered nurses. And then if you add in other psychologists, it becomes 28% of the total workforce. Really strong consultant psychiatry presence as well within the team. So social workers also present in the community, but not in the inpatient team. And the OT presence at 8% is also double what we see in the inpatient team. So very, very good teams here. There's just something about their capacity, given what we might think is happening in terms of demand out there. And this is the demography. So we don't have a huge amount of diversity actually within the eating disorder cohort. It tends to be white British people who are on caseloads. So it's very different from the other psychiatric specialties. So I think the question we need to ask ourselves here is, are services inclusive enough? And I'm sure Agnes and team from Oxford would give us a view on that, about the cohorts that they see within services. Okay, and quick look at CYP. I mean, CYP, it's a little bit more of an optimistic story. I hope I've not made anyone too down with that adult story there, but we tend to see multiples of about 2 or 3-fold in terms of the number of people who access care compared to what we see in adult services. So overall referral rates there, the UK average 137 per 100,000 young people. The South East is again higher, so we're about 10% higher across the region there. So we've got maybe 3 providers there within the top quartile in terms of referral rate. So again, it supports that wider CYP story we discussed earlier in terms of high levels of demand, and that's playing through in terms of eating disorder services as well. And then next up, Ellie, the waiting times. I mean, again, CYP is so much more optimistic. The waiting times are half what we see for adults, but that's really because we have a framework, don't we? We have a target around this one, around 4 weeks, and that is what the regional waiting times are coming in at in terms of that 4-week provision there, both for first. We've got some outliers, so again, that might indicate the capacity v demand position there. Some providers stretching to 5 weeks, but also some providers operating at 2 weeks there. Okay, and next up, Ellie, we got the overall size of the waiting list. So the waiting lists aren't huge in absolute terms. So we're talking somewhere in the region of 42 kids per 100,000 in the southeast waiting to access services. So, but again, if you look at the national split there, you'll see that the southeast is occupying some of those top places nationally. So 3rd highest nationally for first appointments in terms of waiting list size, and then the 2 highest places nationally for second appointments. So again, it chimes in really well with that overall high CYP-MH demand that the region has been experiencing for a long time now. And then just moving on, Ellie, the overall caseloads being supported. Nationally, it's 82 per 100,000 kids. Remember, that compares with about 1,900 or just over that. Sorry, it was 2,700, wasn't it, for the region for overall CYP-MH. So the region there is about 87. So it's about 3% of the region's CYP waiting lists are specific eating disorder referrals and caseloads, sorry. So again, it's something we need to reflect on now, whether we feel that's an appropriate mix within the overall portfolio. Do we have enough dedicated ED capacity at about 3% of CYP-MH provision? And then the contacts, I think, is next. So in terms of overall contact rates, it's within the national range there. Most providers round about the national average. But again, we're talking of multiples of 2 and 3 compared to what we say. It's about 3-fold multiple here compared to what we see for adults. So CYP, there's certainly reasons for optimism that there's quick access. We're delivering at a higher scale than we used to. But adults, unfortunately, is quite static. And there is a big treatment gap evident potentially as well for adults. And Ellie just got a couple more, I think. No, one more. I hope that was okay, Katrina. I mean, it was very much our view from the data, and it's the first time we've done this within the region as well. So we didn't socialize any of that data with anyone. So it was very crude, and it'd be great to get people's reflections on it about how it feels. And Sarah, thanks for your comment in the chat as well.
Brilliant. Thank you, Steve. I mean, just as you said, some of it was very sobering, but just so helpful to be able to look at it from a data perspective, because obviously there's a huge amount of work going on, and there's a huge amount of concern about the level of, what's presenting in services and the treatment gap, but actually to have some of that evidenced is incredibly helpful. Sarah, I think you've just joined us. You're leading the South East All Age Eating Disorders programme. So just thought, you might have some reflections or want to mention some of the work.
Thank you, Katrina. Yeah, I mean, it's really helpful. Thanks, Katrina. And Steve, completely agree. Katrina, it's really, really helpful to have this the richness of this information. I don't think any of it will be particularly surprising to our colleagues on the call who are, are in clinical roles or who are working in eating disorder services or managing them or have commissioning responsibility. I think much of what you've said actually chimes very much with what we already know in terms of what we're being told, and certainly what's coming up at weekly sit reps, for example. I mean, I particularly commented on your point about demography. I think that was a really interesting point about demography and whether we're actually reaching out to all of the right people. I think there's some key questions there. I suppose what I wanted to say especially is that we just know everyone's working very, very, very hard. We know that, and I think it would be really wrong of me to not reflect on that everyone is working very hard. We know that we've seen this unprecedented surge. It was really helpful for you to put that within the context of some of the national data in particular, Steve. And we've I think what I'd like to add in particular regarding children and young people services as well is that we know that there are children and young people with eating disorders who are also being treated in, for example, crisis resolution, home treatment services and other core CAM services as a way of providing either urgent or extra help in terms of their high levels of need. I think it's important to reflect on that, really. As Katrina alluded to, we had a hackathon which was co-hosted with the national team and the South East regional team at the beginning of November, which was KPMG were our partners in that, and we're now on the 30, 60, 90-day hackathon actions. So we're in the place where we are now with our ICS colleagues, pulling together what the community intensive support model will look like, how we will change the way of working into and on acute and paediatric environments, what the workforce requirements is, how we will make sure that that features in second half of the year spend plans, how we're accessing, all the required funding to make that happen, and what we're thinking about in terms of recruitment plan from the 1st of April. So an awful lot going on, as you know, Katrina, and just ever grateful to all of our colleagues that are on the call with us, if that makes sense.
Thank you, Sarah. That's really helpful. I don't know if there's any other thoughts, reflections, questions, anything else from anybody, either hands up or chat. I can't find anything else. Emily, have you joined to ask something? I saw
hello. Yes, I just flashed up. Thank you. Just a quick question for Steve about the workforce particularly and the skill mix for the workforce, and just a reflection. I can't speak for the adult services, but for the CYP, can I ask whether the workforce in the GAU/ED pathway were also used as well as the specialist eating disorders, or was it just the specialist eating disorders, because there's two separate pathways?
That was just specialist eating disorders, Emily, but I think we would have the same observations about the GAU, where the skill mix is pretty thin, with respect to the teams who are working incredibly hard there. But the that question again, would we design it this way? Because there's a huge reliance on unregistered nursing staff to meet shift rotas and the therapeutic core. Unfortunately, in CYP, as you go through the acuity bandings, and this is a completely sort of, it's a non-scientific statement. But if you assume GAU, maybe eating disorders, and then maybe secure forensic as different levels of hierarchy, unfortunately, the skill mix gets worse the higher up the hierarchy you go in terms of therapeutic core. And again, it's that question: would we design it this way throughout? And whether these are system-induced unintended consequences almost. I think there's an opportunity for a lot of reflection on that, and maybe the next one of our sessions we can maybe bring some of that work that's taking place in the Northwest, and maybe share some of that about their wish to sort of re-engineer and redesign it in future.
And certainly with the Microsoft Teams meetings that we've got as well, I'd be really interested in those international models that you were talking about from Sweden and Australia as well, particularly about the length of stay and the increased occupancy throughput as well, in tangibly how that was done. We've seen it from a national perspective, and really great models, eating disorder models, but it'd be great if there's any opportunity to have an international perspective as well. Thanks.
Thank you. Sarah.
Sorry, Katrina, I should have added as well. And I think Emily has just reminded me that on the 15th of December, Olivia Fajarat-Jones, our Director of Delivery in the mental health team, is hosting a webinar which is focusing on intensive community support, including for children and people with an eating disorder where there's co-occurring neurological condition or ASC, for example. And if colleagues haven't had access to the agenda or the flyer, please do let us know in the chat, and we'll make sure that a copy is sent out. I think will be helpful, thinking very much in the context of the intensive community models particularly, and next steps, and we're sharing some best practice from within the region, but also across the country as well.
Thank you, Sarah. It looks like I'm just going to check chat. I don't think we've got anything else coming through, but just as always, a very thought-provoking and really helpful presentation. So thank you very much, Steve and colleagues, as was the earlier session as well. Huge amount to learn, and useful to have a bit of space to reflect as well. But we're actually incredibly well timed, 1 minute early, for a quick break. So just a 10-minute break, and the final section is going to be kind of a bit more of that reflection time around how you're using the modelling tools, what's helpful, and also I think a bit of a discussion about thinking about next year and the work with NHS Benchmarking colleagues, and really wanting to get the views of people in this meeting around what would be helpful, so we can really shape an offer moving forward. If you could, it's probably easier to stay on the line, I would imagine. I'm going to do that and just take a 10-minute break, and we're going to come back at 20 past. So thanks everyone. Session today. So we're just, I mean, it says until 1:45, but we'll see how we do. We might not need that long. It's never easy having an interactive session when there's quite a few people on Teams, but we're going to try. It would be just really good to hear from, certainly Michelle's posed some questions around what you're using in terms of modelling, or really looking at kind of having ways of really having that kind of look at your data, and how are they supporting demand and capacity issues. But just wondered if you and colleagues, Steve, had anything you wanted to add. I mean, I mentioned earlier before we had the break that it would be great to get some thoughts around where we go from here. I mean, certainly we're really keen to continue to work with NHS Benchmarking colleagues moving forward, but we'd love to hear from everybody in this meeting about what's helpful, what would you like, what area of focus, and, you know, I think really importantly, what do you do with it after the sessions? How's it informing kind of taking steps forward? I think which was the challenge really from you, Steve, around the last session in particular. Was there anything, Ellie, Steve, just to add to that?
I think it's a really good intro, that, Katrina. You're right. It can feel a little hard sometimes to get these discussions going on top of everyone's day job about, you know, this sort of horizon scanning. I think from an NHSBN perspective, we've really enjoyed working with the regional team in the last 18 months, and obviously we have long-standing relationships with the providers, but it's been really energising to have that conversation with the systems as well. So, you know, we've learned a lot, and we've been really impressed actually by the data, the intelligence that informs, you know, the full work program, and then the projects that are active. That, you know, there are many of them, and obviously they serve a purpose in terms of making sure that the region keeps pace with the LTP aspirations, etc. From an NHSBN perspective, I just wanted to say that we will be carrying on with our monthly data collection, you know, which facilitates that presentation we did at the start for the rest of, well, for 22-23. So that sounds a long way off now, doesn't it? But we will, we've got a commitment in our own organisational business plan that we're going to be sourcing this stuff from providers, and, you know, Julian's on that group that sets the strategy for us. So I think that's really important, that we will have a really good data flow. And although, of course, we all started this with that aspiration, we needed to do it because of COVID, because there was a lack of evidence at the start of the pandemic. I think we're in a position now where we've got good evidence and a good shared understanding. And actually, maybe the understanding of the concept of what we mean by a surge is subtly altered as well. You know, we're not talking about short-term peaks in demand, but we're about understanding how the system connects, and the data can give us some really big clues on that. You know, so what's happening on inpatient provision, what's happening on community referrals, those really important nuances like face-to-face care, digital, telephone, etc., which started to move us into that quality space as well. Excuse me. So it's not just about the extent to which care is being provided and how it's changing, but it's about what we're trying to achieve with it. So we're going to carry on. So we'll have the data, and I think it's probably fair to say that the tools that we produce for the region have evolved as well over the last 18 months or so. So we're really keen to get people's observations about the value they add, what you find most helpful, and as you said, what people are doing with it. But I think above all, what these tools do, and I hope that people sort of recognise this, is that they bring the empirical evidence into the discussion, and they bring that in a very timely manner. And often, without the empirical evidence, we're in danger of chasing anecdotes. And I'm hoping that the empirical evidence has introduced a degree of calmness almost into this sort of really intensive process that the whole region has been working in for the last 19 months. So I'm not sure whether that helped, but I think that was our reflections. And I mean, we're not the only tool in town either, are we? There's other things that people are using, and it'd be really great to get people's thoughts on what they found helpful there as well.
Brilliant. Thank you, Steve. That's really helpful kind of framing. And again, I don't know if any thoughts, reflections, chat, put your hands up. A number of kind of questions there, but it would be great if people could share any of that in the meeting, and also thoughts for next year as well would be great around any potential areas of focus. Sarah.
Thanks, Katrina. Sorry, just coming off silent then. Just jumping in, I guess, really. And this is just me embarrassingly thinking off the top of my head. Just wondering, Steve, because you did such a great presentation at the Acute Forum last week as well on the impact of mental health on the UAC pathway through, our acute hospitals. And I just wondered if at some point there may be an opportunity, and it's just me, Katrina, so do please tell me if it is just me. I just wondered if there might be some opportunity for us to come together and sort of almost do a bit of a triangulation, around, to use Nick Broughton's expression, the elevator pitch. Do you know what I mean? So this is with these great pieces of work that NHS Benchmarking have done for us, because there's a danger that we talk to our colleagues in the UEC and urgent mental health pathway about those bits, not the ED bits, and vice versa. Does that make sense? And just wondered if there's almost an opportunity for us, because it is so helpful. And there was an incredible moment last week, Steve, where you showed us your slide about ambulance handovers and how that correlates with Trust sort of got mental health liaison, or good, robust mental health liaison. And that was an incredible moment for me, because the national team are increasingly talking to us about national ambulance handovers, and how can mental health, how does mental health flow impact upon, handover delays, essentially, in acute settings. So there was a moment where the most current national thinking was starting to join up with what you were telling us, if that makes sense. So I just wondered if there's an opportunity for us, Katrina, if I can talk to Steve offline about our elevator pitch, if we could bring that all together. Does that make sense?
Yeah.
It's a really good point, that, Sarah. I think that's an illustration, because Nick, there's almost this intuitive feel that having great liaison service, or liaison services with enough capacity, can reshape the prospects for people with a mental health problem in the emergency department. And we've got enough clues on the evidence, actually, that can and does help. So I think it was a great illustration of the power of the evidence. And I'm just thinking out loud now, that I think one of our conclusions in our report was that it would, although that was a one-off piece, it was almost a non-recurrent piece. It would be nice to almost curate that data flow on an onward basis, and it could be done through a modelling tool as well. I mean, the acute provider world is obviously a bit more fragmented than the mental health provider world, because we're talking about many more providers, and actually capturing the data can sometimes be a problem. But there's no reason, you know, as we move into ICSs, why that data couldn't be mobilised at ICS level. So I think there are opportunities around getting maybe an enhanced level of understanding with people as we enter that ICS phase as well, because you know, the mental health world has become really comfortable and really sophisticated actually using data in the last few years. But I'm not sure, you know, that there's probably going to be some learning, I would guess, in the early months of the ICS.
Sorry, yes, I think that's really helpful. Thanks, Steve. I completely agree. And I guess for me, I was thinking last week, actually, when we were doing a presentation, that there was when we did the, I mean, Emily may recall when we did the one-day audit in acute and A&Es of mental health delays, both CYP and adults, it looked like we weren't an outlier actually for numbers, but we were an outlier for lengths of stay. And that seemed to be telling a story, both children and young people, around eating disorders. That seemed to be what the story was in particular. So I really do think there's particular opportunity to perhaps join those particular pieces of work up, if that makes sense.
Thank you, Sarah.
Thanks, Sarah. That's really, really helpful. And I think it picks up your point, Steve, about actually we've got a pretty good evidence base now. So our entire discussion this afternoon is on the basis of that really evidence base. So it's the kind of, so what, now what, you know, where do we go with this? And your point, Sarah, is really important, which is how do we absolutely be embedding some of this in some of the work that's happening, rather than it being something that kind of sits outside. But Emily.
Hi, thank you. Thanks, Katrina. And yeah, just building on that, really, we've got a really good opportunity here, particularly with winter pressures going on as well, for two things. So in response to Steve's point earlier about quite often people will say that they either don't have the time or the capacity to do forecasting. My response to that immediately would be, well, that's where you flush out where all the gaps are. So in our experience in the South East for CAMHS Tier 4, when we've done that capacity and demand modelling and forecasting, we've immediately been able to outline even if it's wrong, even if the modelling for a particular service for eating disorders, for example, turns out to be wrong, it flushes out the conversation and go, okay, if it's wrong, how is it wrong, and where are the differences across the region? So it flushes out those immediately, and it strengthens the network, which Steve was alluding to, particularly between the CAMHS and paediatric teams. The other point I would say is in winter pressures as well, we've got a regional operational centre which is linked into the EPRR, which is the model that helps us identify the bed occupancy within the acute hospital trust. So that dashboard is already available for winter pressures. So it's about moving that forward into the future and continuing to use that and embedding that, like you say. So Sarah, Olivia certainly is on that meeting at the moment. I'm on that meeting for Tier 4. So we link into that already, and already those conversations are coming up. So we know what the bed occupancies are, we know where the hotspots are, and more importantly as well, we know which of those are mental health patients. And so we're talking about that bed capacity already in the acute hospital setting as well, so we can link into that and take it forward past winter pressures.
It's brilliant, Emily, thanks. And again, the both, well, especially the CYP ED worries, both in terms of the volume and the acuity of referrals, and to some extent the complexity of them. You know, as you know, Emily, features sort of pretty much every week at Tier 3 sit rep, if that makes sense. So I think we're getting an understanding of some of the pressures that our colleagues are working under, and obviously just want to support and be as responsive as we possibly can in connection with that. I think your point about seasonal pressures is absolutely brilliant, Emily, not least because sometimes when we're thinking about expediting a particular delay, we do think about what we call the non-Tier 4 options around personal health budgets, etc., community care packages, etc. So I think this is all funding that hopefully will be of use to ICSs over the winter and beyond.
Thanks, Sarah.
Thank you. Just a request, really. It would be helpful if people could just add into chat something about anything that they have been doing, using, anything they, any areas that they feel they'd like to develop more, any feedback around this work moving forward, and anything about the how do we kind of, where do we go with this? What do we actually do with it, and how could we potentially work across the region to support that. But Phil, I don't know if you wanted to ask a question, because I know you've just come up on the screen. No, hi Phil.
Sorry, it's my inability to use Teams correctly. My apologies.
Oh, no, don't worry. That's fine. So, and that's my dogs in the background, so apologies for me. Any other thoughts? Just again, in chat is brilliant, and I can just see you've made a point there about data modelling. Really helpful. Anything else just before we finish? Louise, hi there.
Hello, just real quick, and I have sort of launched into this meeting a little bit late, so I've missed half of. I saw the beginning and the end bit, the CCAM bit, the people being locked in A&E, and those handovers is really interesting to me, because I'm starting to really lean into that urgent care conversation as far as participation, with my role as the mental health participation programme lead, really trying to generate a conversation for having participation that works across the system, and really trying to unlock what we know. We've got all that insight, and I really like hearing the so what bit, because I'm really sticking on the so what bit in Sussex around, yes, we've got lots of insight, what are we going to do with it, and how do we do that through connection and understanding of each other's layers of the system response to people's difficulties in A&E, ambulance, police and so on. So I'm really pleased to hear this is what you're getting around, and if I can support and help it, please get in touch and I'll launch into this as well.
Thank you, Louise. That's really helpful. And I guess one of my reflections is we've had, quite a good turnout for this meeting, but given the number of people working out there in systems on different programs, it's actually relatively small.
Yeah.
How do we get some of the incredibly important evidence, as you were saying, Steve, but also intelligence that we're sharing kind of out there, because I think it's absolutely critical. I mean, when you showed the data about the inpatient ED workforce, I mean, just what are we going to do with that? That's actually shocking.
Yeah, it's fascinating actually, and me and the team have been really impressed by that sort of teamwork we've seen across the South East system, and it's really quite evolved actually, and the fact that we can be honest with each other about our reactions to the data is really important too. So as Louise said, that using this as a route to engage with lots of people, but as a sort of regional lead, Katrina, I sort of commend that you had the same reaction as me there. We would want to change that and sort of lead on the front foot with a sort of therapeutic offer for people.
And actually, in Sussex again, the neurodiversity allocation of funding, because there's an awful lot of crossovers with neurodiversity, urgent care, ED, and lots of different things that actually cross over with the autism bit. With somebody quoted on Twitter this morning, it's very easy to get a diagnosis of PD. You can get that in a week, but it takes years to get an autism diagnosis. And actually, we've only got 3 people in West Sussex, I think, and it's just ridiculous. The kind of the allocation of resources to those specialist things really help to unlock this.
Yeah. Do you know what I'm thinking there? I mean, you're right. Neurodiverse issues it's a really weak bit of NHS data actually at the moment. And I've been having discussions with the national team on this one, and also with HEE. And we do collect some really good data on learning disability and autism services at trust level, and there might be an opportunity, just thinking out loud now, Katrina, because obviously we've got a reasonably tight framework of the stuff that we include within this data spec, and we haven't talked about learning disability yet really in the 4 or 5 seminars we've had, and that very broad definition of LDASD might be something that we could add to the list for next year as well.
Yeah, I mean, sorry, I'm going to bang on a bit. Every time we have people that come in with the EUPD, we've got those types of things, settlement crisis, quite a few people have got that ASD sort of traits and stuff. Mostly from hearing from different people that work in that environment, ASD is presented when there's trauma, and we're not really connecting some dots on that as well. And so I think people waiting a long time for a diagnosis of neurodiversity are going to have, in the meantime, might get into a mental health crisis then get misdiagnosed or re-diagnosed or something, and it just creates and exacerbates problems that people face at that level.
And certainly some of the work, Sarah, that was done around the inpatient, that the kind of the length of stay in inpatient, actually what was coming through from that was actually some of the folk with a kind of neurodiversity presentation were really impacting on length of stay. I don't know if that's true. I wasn't able to come to that meeting, Steve, that you had, but really important questions. But just a really very, very big thank you to colleagues from NHS Benchmarking, Steve, Ellie, always for making me think. And I think in many ways it's interesting. It's through the lens of evidence-based, but it's actually in the way that the data is presented. It really brings the person into the centre of it, which is, of course, why we're all here. So just a really, really big thank you to all of you for that. We're keen, again, add anything in the chat or email myself or Michelle if there's any thoughts and suggestions about areas of focus moving forward. Unfortunately, Michelle's got a power cut, so she's having to sort that out at home, but I will feedback this discussion. So yeah, again, really big thank you. We will send everything round. Please do, I guess a plea from us is do send around the recording to colleagues, as well as the slides and the modelling tool as well, so we can really get this stuff out there, as well as the previous ones that are also very, very good, that picked up on different themes. And again, very big thank you to everyone, and look forward to seeing you next time. Oh, and in fact, we have a date. So excuse me, 8th of March, 2 till 4 is the date of the next session. All right, thanks everyone. Take care. Bye. Bye.